Hello, and welcome to the Parkinson's Foundation Wellness Wednesday webinar. The Parkinson's Foundation is committed to enhancing the lives of those living with and impacted by Parkinson's disease. We focus on improving care and advancing research, ensuring that all our efforts are closely aligned with the needs and priorities of the Parkinson's community. Not every person with Parkinson's disease will develop psychoses or its symptoms, but it can still be a frightening thought. Hallucinations and delusions can be common in PD, but understanding what it means in Parkinson's and how a person may experience symptoms can ease the fear and embarrassment that may result. In today's webinar, we will learn the causes, related symptoms, and how to address symptoms of psychoses. We want to thank this webinar's sponsor, Acadia Pharmaceuticals, for supporting the mission of the Parkinson's Foundation. Thank you, Acadia. The Parkinson's Foundation is proud to offer PD Health at Home, a virtual program series designed to provide education, wellness, and community support directly to your home. Each week, we host a variety of sessions tailored to enrich the lives of those affected by Parkinson's and their care partners. These weekly programs are free and accessible to everyone, providing an invaluable resource for staying connected, informed, and engaged in your health journey, all from the comfort of your home. Learn more about what we have coming up and check out our archived videos on YouTube by visiting the webpage parkinson.org/pdhealth. And now to introduce our speaker, Dr. Sarah Horn. Dr. Horn is a dedicated assistant professor of neurology at UT Health San Antonio, specializing in the care and treatment of individuals with Parkinson's disease and other movement disorders. With advanced training through a prestigious fellowship at the University of Pennsylvania, Dr. Horn developed a passion for improving care through comparative effectiveness research. As the principal investigator of a groundbreaking clinical trial, she is exploring the most effective medications for managing hallucinations in Parkinson's disease. Beyond her research, Dr. Horn is committed to shaping the future of neurology by teaching medical students and residents, and serves as the director of the Parkinson's Multidisciplinary Clinic at University Hospital in San Antonio. Her compassionate approach and expertise make her a trusted advocate for patients and a leader in the field. Dr. Horn, thank you so much for sharing your time and expertise with us today. And I'm going to stop sharing and you can go ahead and share your screen and share your slides. Thank you so much.
Thank you, Donna, for that very kind introduction. Let me pull up my slides here. And thank you to everybody who's joining. I'm delighted to be here to talk to all of you about hallucinations and delusions in Parkinson's disease. These are my disclosures. And today we're going to talk about what psychosis is in the setting of Parkinson's disease. We're going to learn how psychosis impacts people with Parkinson's and the people around them. We'll talk about ways to respond to a person with Parkinson's who's experiencing psychosis. And then I'll review some strategies for management of hallucinations and delusions in Parkinson's disease. I want to start by talking about some background information about Parkinson's disease. It's the second most common neurodegenerative disease behind Alzheimer's disease. It affects 1% to 2% of people over the age of 65, and it's a progressive disorder. It's caused by a loss of brain cells, neurons, particularly ones that make dopamine. So we call this a neurodegenerative disorder. It causes a constellation of symptoms, both ones that have to do with how a person is able to move. We call these motor symptoms, as well as non-motor symptoms. The motor symptoms are the hallmark of the disease. These are the symptoms that people think about when they think about Parkinson's disease, such as a tremor. The tremor in Parkinson's It is a particular type of tremor called a rest tremor. That's there when the arm is at rest in the lap or by your side. And then the hallmark movement symptom that Parkinson's causes is slowness of movement, or we call this bradykinesia. And that can be seen in a variety of ways, like reduction of facial expression, or decreased arm swing when walking, or trouble with fine motor tasks and using your hands. And then Parkinson's also causes stiffness, and we call this rigidity. So these motor symptoms are the way that we diagnose the disease in the clinic. So according to the most current diagnostic criteria, in order to diagnose Parkinson's, you have to have that slowness of movement, the bradykinesia. And then in addition to that, there needs to be the stiffness and or the resting tremor. But for many people, the motor symptoms are what you see, but they're just the tip of the iceberg. And beneath the surface is a whole host of non-motor symptoms. And these can range and affect quite a bit and affect a bunch of different bodily systems, from the gut to speech to sense of smell, low blood pressure issues, but also memory, thinking, mood, and hallucinations. In the brain of people with Parkinson's disease, the hallmark finding that we see under a microscope is called Lewy bodies. So this is a picture of a brain cell, a neuron under a microscope, and this is somebody who had Parkinson's disease when they were alive. And this arrow is pointing to this spherical inclusion that's within the cell, and it's called a Lewy body. And these Lewy bodies, as the disease progresses, propagate from one neuron to the next. According to a hypothesis by a scientist named Brock, it is thought that the Lewy bodies and the changes in the brains of people with Parkinson's disease begin many years before any of those movement or other symptoms begin. They start at the bottom of the brainstem in this shaded area in this picture. And then as the disease progresses, those Lewy bodies spread upwards to affect the areas of the brain that are involved in movement. And then people start getting tremor, slowness, stiffness. And then as the disease progresses further, those Lewy bodies spread up and out to what we call the cortex, which is the surface of the brain. And this is the part of the progression of the disease where people usually are experiencing things like hallucinations. As those changes are happening in the brain, both those motor and the non-motor symptoms are progressing. So if you look at people who have had Parkinson's for 20 years, so these are people who have more advanced Parkinson's disease, then these non-motor symptoms are really common. Over 80% have dementia, sleep issues, dizziness problems, bladder problems, speech and swallowing problems are really common. And about 3/4 of people 20 years into their disease will have hallucinations. The classic description of hallucinations in Parkinson's disease is that of visual hallucinations, and specifically well-formed, vivid, non-threatening hallucinations that people see, such as this person and sitting at the dinner table who sees extra people and animals around him at the dinner table. Just like everything else in Parkinson's disease, there's no one-size-fits-all experience for hallucinations in Parkinson's. So although if you go online and read about hallucinations in Parkinson's, this is probably the description that you're going to read about, the actual experience from one person to the next with hallucinations can be quite variable. So more broadly speaking, hallucinations, I put here on the slide that the technical definition for hallucinations, but basically it's whenever people see or hear or feel, or smell, or even taste things that are not there. And hallucinations can affect any of the sensory modalities. They can be simple, like just seeing a shape or a shadow or a light. Or they can be complex, like seeing a small animal run across your path in front of you. There was a study that was published that looked at the types of hallucinations that people with Parkinson's disease have. And they surveyed 116 consecutive people with Parkinson's disease as they came into a Parkinson's disease clinic. And they asked them about whether or not they had hallucinations, and if so, what kind of hallucinations they had. And this is what they found in this figure on the right. So of those 116 people, 42 had hallucinations. So it's quite common, just in a random sample in a Parkinson's clinic. And among those people who had hallucinations, 16 had visual and 18 had auditory hallucinations. So in this study, at least, the auditory hallucinations were more common than the visual ones, which was surprising. And then it was also interesting that it was not uncommon at all that people were having tactile hallucinations where they could feel something on their skin, like, for example, bugs on the skin that aren't there, or sensations that they were smelling things that weren't there, or even tasting things that weren't there. So the experience with hallucinations really can be quite broad. And a lot of people who have Parkinson's related hallucinations have multiple different types of hallucinations as well. Minor phenomena are like a milder form of a hallucination. So one very common one in Parkinson's is called a presence hallucination. And this is a sensation that there is somebody else in the room when nobody is actually there. So, for example, if a person with Parkinson's has this type of hallucination, they might set an extra place setting at the dinner table for a family member who they think is there and joining them for dinner, but that family member is not actually in the home. And then there's also illusions. Illusions are whenever there's an actual real object that's there, but it looks like something different. So for example, you see a fire hydrant as you're driving down the street, it might look like a small child or a dog, and that's an illusion. And then there's delusions. Delusions are false fixed beliefs. And these beliefs are maintained despite evidence to the contrary. In Parkinson's disease, it's common that these delusions will be paranoid in nature. So people might be worried that there are intruders that are coming into the house. They might worry that their spouse is cheating on them, or they might think that a family member is stealing money from them. And these delusions can be really distressing to the person experiencing them, and also to the caregivers and family members around them. And the person who's having the delusions does not have insight into the fact that these things are not actually happening. So for the person with delusions, they really do believe that the spouse is cheating. So it can be distressing. When we use the word psychosis, that is an umbrella term, and there is criteria that have been published for how we define psychosis in Parkinson's disease. But basically, you need at least one of those phenomena that we've talked about already: the illusions, the false sense of presence, the hallucinations, or the delusions. And it needs to be in the setting of Parkinson's disease, there for at least a month, and then without a better explanation for what's causing it beyond the Parkinson's disease. It's a quite common occurrence in people with Parkinson's. So we talked about how if you have somebody with advanced Parkinson's, 20 years into their disease course, about 3/4 of them will have hallucinations. If you just take all comers with Parkinson's and follow them along their disease course, up to 60% of people with Parkinson's will experience hallucinations at some point during their disease. So it's really common. Most people with Parkinson's will experience this at some time or another, and but it's not often talked about. So I'm glad that we're dedicating an hour to talk about it today. Generally, for most people who have hallucinations in Parkinson's, they tend to start out mild with those minor phenomena. So they might begin with occasional illusions or a sense of presence, or shadows in the peripheral vision. Those are called passage hallucinations. And usually they're not that bothersome in the beginning. As time goes on, they might become more vivid and well-formed. So instead of seeing shadows, you might start seeing small people or animals that aren't there. But in the beginning, usually people can still tell what's a hallucination and what is reality. As it progresses, sometimes the hallucinations become more severe and people lose that insight into what's a hallucination and what's not a hallucination. And then Parkinson's psychosis in its most severe form usually involves delusions, where people don't have insight into these fixed false beliefs that they have. And when it's severe, the psychosis can be distressing. In terms of why Parkinson's causes psychosis, we think it's multifactorial. We talked about how the Lewy bodies progress and spread to the cortex of the brain as the disease progresses. And this progression of the disease is certainly one of the reasons why Parkinson's causes hallucinations. But in addition to that, the medications that we use to treat Parkinson's disease also contribute to the hallucination. So here I've listed all of the classes of medications that we have available on the market to treat Parkinson's disease, and they all can exacerbate hallucinations. So sometimes it's a balance of making sure that we're adequately treating the tremor, the bradykinesia, those bothersome motor symptoms, without making the hallucinations worse to the point where they're really distressing. In addition to Parkinson's medications, there are other risk factors that have been identified as being associated with developing psychosis in Parkinson's disease. Another big culprit is other classes of medications, particularly psychoactive medications like sleeping pills, narcotics for pain control. There's medications called anticholinergics that are notorious for causing hallucinations, and these medications are prescribed for several reasons. Bladder issues is a really common one. Drooling is another common one. Benadryl has some anticholinergic properties in it. So even over-the-counter medications like Benadryl can be at play whenever people are having hallucinations. And then the severity of the Parkinson's disease is also associated with developing psychosis. Sleep issues are very common, and it's common that people will have hallucinations that are worse at night when they're trying to go to sleep. Older age and vision problems are also associated with hallucinations. Having that sensory input from being able to see clearly is really helpful to know, to ground people in reality, to help know what's real and what's not. And then cognitive impairment is very common in people with Parkinson's who have hallucinations. Dementia from Parkinson's tends to go hand in hand with hallucinations from Parkinson's. That's not 100%, but it's common that they go together. I wanted to talk about sudden onset of psychosis in Parkinson's disease, because I think it's worth talking about how this is a little bit different. So for most people, like we talked about, the hallucinations tend to be gradual over weeks, months, years. If all of a sudden the hallucinations begin, then that's a sign that there's something else going on beyond just the Parkinson's progressing. And it's a trigger to do a workup with your doctors to see if there's something else going on that's treatable and reversible. One of the most common reasons is a change in Parkinson's medications. This is a list of a mnemonic of different things that can trigger sudden onset of hallucinations in people with Parkinson's. So looking for recent med changes. And then looking for underlying medical issues. So kidney problems, liver problems, heart problems that are exacerbated. Infections. Infections are notorious for causing hallucinations, particularly urinary tract infections. And sometimes people will have a sudden onset of hallucinations whenever they lose their glasses and hearing aids because of that sensory deprivation. So that's something else to think about. And sometimes doctors will order brain scans to make sure that there's not something structural going on that triggered the hallucinations as well. Psychosis in Parkinson's disease can affect the person with Parkinson's and their family members in a variety of ways, particularly if the psychosis is more severe. It can come with some behavioral disturbances. And you can imagine that if a person is having delusions that somebody is trying to attack them in their house, that can lead to some behavior changes, agitation that can be difficult. Psychosis is associated with an increase in caregiver burden, as well as a decreased quality of life for the person living with Parkinson's disease. Psychosis is one of the largest drivers of nursing home placement for people with Parkinson's disease. It's also associated with more rapid cognitive decline. And there's an association of psychosis with increased mortality. So it's not, especially when it becomes more severe, it can be a distressing condition. It's not necessarily benign, and it's worth knowing about and worth talking to your doctor about. So we spent some time talking about what psychosis is, how it can affect you, and now I wanted to take some time to talk about treatment options. Step number 1 is addressing underlying triggers and risk factors that could be causing the hallucinations, because sometimes these things are reversible. And then addressing the triggers can make the hallucinations get better or go away. So it's important to optimize sleep and mood issues. So severe insomnia, severe depression are also associated with hallucinations. So it's important to optimize these things the best that you can with your doctors. Use the glasses and hearing aids to optimize the sensory stimuli that can help with orientation. It's worth regularly talking with your doctors and going over your medication list to see if there are medications on there that you don't need anymore. Whenever people have to take a lot of medications, we call that polypharmacy. So we can reduce the polypharmacy, take off some meds that aren't needed anymore that might have a potential side effect of hallucinations. Then I think that's worth revisiting from time to time with the doctors. And if you're having hallucinations, particularly if they're worsened recently, it's worth looking back to see if there might have been a recent medication change that seemed to trigger that worsening of hallucinations. And then, of course, identifying and treating infections, urinary tract infections, other infections, constipation, other medical issues that could be triggering or worsening the hallucinations is very important. Those things don't work, then often we'll talk about reducing Parkinson's medications next. And I put that list back up here. I ordered this list with the biggest culprits at the top. And then thankfully, carbidopa levodopa is all the way at the bottom. So if I have a patient with Parkinson's psychosis and they're on an anticholinergic, this is for Parkinson's. These anticholinergics are medications like benztropine or trihexyphenidyl. Or if they're on a dopamine agonist, these are medications like Pexol, ropinirole. Those are usually the first ones that I try to get people off of, because those classes of medications are the most notorious for causing hallucinations. then I kind of go down the line, and if it's always a balance, because sometimes people with Parkinson's can't tolerate lowering their Parkinson's medication. But if they can, or if we can, lower one of the more culprit classes of medications and substitute it with like carbidopa, levodopa dose adjustments, then sometimes that can help the hallucinations. Then there are behavioral strategies that can help. Caregivers can provide reassurance and help reorient people, especially if they're having trouble knowing if a hallucination is real or not. I would encourage caregivers out there to always try to maintain a calm environment whenever you're reorienting. I have some patients who will reach out and try to touch a hallucination, and that'll make the hallucination go away, or they'll look away and that will make the hallucination go away whenever they look back. So some of those strategies can help for some people. Turning on a light can be helpful. So lighting up a room can help, reduce hallucinations. Sometimes people are seeing hallucinations in the shadows at night. And I think that, if those things don't work and people are still having hallucinations, having trouble knowing that the hallucination is a hallucination, and have lost that insight into it, I just would urge caregivers to pick your battles and not argue about it, because trying to force the matter that the hallucination is not real is probably not going to help the hallucination go away for the person experiencing it. Rather, that's probably a sign that it's time to talk to your doctor about medication options. There are medications that are available to treat hallucinations in Parkinson's disease. Oftentimes we'll start with these non-medication options first, but it's not uncommon that people with hallucinations from Parkinson's really benefit from starting a medication specifically for the hallucinations. So you can talk to your doctor about options if you're at the point where you feel like you'd benefit from starting a medication for psychosis. And I also think it's important to think about safety implications and have a plan. So in case the hallucinations or the delusions did become more severe. So for example, if there was a urinary tract infection or COVID infection or something that triggers the hallucinations to be worse, what are your options? What would you do in that situation? If there's somebody who's getting agitated because of delusions that are really distressing, then it's probably a good idea to make sure that there aren't accessible weapons to them in the home, because that can make for a dangerous situation that could be avoided. And then it's important to have a list of emergency phone numbers in your phone in case you need them, and then list help. So if your loved one is having psychosis, talk to family members or other friends or neighbors, because it can be important to have other people helping you out for a variety of reasons. So I have some patients who, whenever their hallucinations are worse, they like to talk on the phone to a family member about them. So if you, have a go-to family member who knows that sometimes they might get a phone call whenever the hallucinations are bad, and that they can be a listening ear, and sometimes that helps calm people down. If severe, which for the vast majority of people who have hallucinations with Parkinson's, it does not become this severe, but in some people it does. So I think it's worth talking about. If they become severe and the person experiencing gets agitated, we have to think about safety. So give them space, go to a different room, leave the house if you need to, and assess the level of danger. both for yourself and for the person experiencing the delusions or severe hallucinations. And if you're fearing for their safety or yours, that is a situation where you would call 911. A lot of police departments have crisis intervention teams, and these are officers who are specially trained to respond to situations where people are agitated because of medical reasons, like hallucinations and Parkinson's or dementia. And they will help get you safely to an emergency room for evaluation to look for those triggers, like urinary tract infection, and for stabilization. Sometimes people who have a bad exacerbation of their hallucinations need to be admitted to the hospital in order to get the hallucinations under control. Sometimes people are able to come home, and other times people move to a nursing home with a safe memory center there if the hallucinations aren't able to be managed at home anymore. So in summary, we talked about what Parkinson's related psychosis is. We learned how it can affect people with Parkinson's and their care partners. We talked about ways to respond to people if they're having symptoms, and we talked about some management strategies for Parkinson's psychosis. I did want to leave you with some pearls. Number one is talk to your doctor about hallucinations. So if you're experiencing it, you're not alone. And there are several treatment strategies available to help reduce the hallucinations. It's help from family and friends. I think a lot of people with hallucinations are embarrassed by them. They don't want to talk about them. But, I would encourage you to let people in so that you're not walking the journey alone. And I mentioned before that I think it's important to go over the med list with your doctor periodically, see if there's meds that can be reduced, removed, if you don't need them anymore. If there's a sudden change in health, including a sudden change in hallucinations, then see your doctor to look for a trigger of what might be going on. It's important to try to optimize sleep, mood, and general health as much as you can. It's good for overall physical health, brain health, and can also help hallucinations as well. Optimize vision and hearing. That's important for hallucinations, social life, and also for cognition in general. And if you're struggling with Parkinson's symptoms, be it hallucinations or another feature of Parkinson's disease, and you're not already seeing a movement disorder specialist, I'd encourage you to look into seeing a movement disorder specialist. And have a safety plan. And then lastly, the Parkinson's Foundation has a lot of excellent resources on their website, and you can visit their website and continue to come to activities like this so that you can stay up to date and in the know on how to live with Parkinson's. So I'll end there.
Great. Thank you so much. So we have quite a few questions that came through, and then we had some that came through with the registration, and we have lots of time to be able to answer some of those, so that's great. So great presentation. I think you broke it down so well. You talked about sudden onset, and you talked about some things that could bring on hallucinations quickly. A couple of people actually asked about hospitalization. So they have loved ones who've been hospitalized, and after a couple days, now they're suddenly starting to experience hallucinations.
Mm-hmm.
Would some of those things you talked about as far as sudden onset be contributing to that when they're hospitalized?
Yeah, absolutely. So this is very common. And I'm assuming that in those situations, we're talking about people who were hospitalized for non-hallucination reasons. So something else happens.
Something else.
Something medical is going on, and people are in the hospital. So we see this very commonly, whether or not people have Parkinson's, actually.
Yeah.
In the hospital, people are there because they're sick. There's some sort of infection or other issue going on, and it's a different environment as well. People are not in their normal pattern, they're not in their normal situation, and they're not sleeping well. People do not sleep well in the hospital, and this whole milieu of, different things can trigger hallucinations really commonly. So, including in people with Parkinson's disease.
Right.
So we see that a lot.
Okay, that's good to know. So yeah, great strategies. Obviously we have a lot of care partners or family members who are watching today. And you did address some of that. We got quite a few questions about, going along with it. So if the hallucination or the delusion even is not harmful per se, is it okay to go along with it? Is it okay to, allow it to continue or to feed into it if it's not harming? Like, how would you respond to that?
Right. So I think that there comes a point where reorientation does not work anymore, and then it's not worth arguing.
Yeah.
So you can try to change the subject, try to gently redirect. I wouldn't try to feed into it to, kind of exacerbate the
Right.
hallucination. But I think that to a certain degree, going along with it is okay and appropriate in many
Mhm.
situations.
Okay. Yeah, some people have even said their loved one finds comfort in it.
Mhm.
So that, so they're hesitant to shut it down, so to speak. So, okay.
Right.
Um, a question here about, and actually we had a couple of questions about this, feeling dismissed by their healthcare provider about them witnessing a psychosis type episode. So the doctor is not necessarily believing that the person's experiencing a hallucination or delusion. How would you recommend that they handle that?
That's hard because I don't want my patients to ever feel like they're being dismissed. When they're bringing up a concern, I'd say bring it up again.
Yeah.
And if you feel like a doctor's dismissing, you can say, I feel like you're dismissing this symptom. Can we talk about this more? This is really distressing. Because it might be, it's hard to know. I'm not in those situations. But it could be a variety of things. And maybe the doctor didn't understand that it was something that was bothering you that you wanted or needed addressed in that situation. So just making sure that they know that we need this addressed.
Right. Right. Now that makes sense. All right, let's see. So this question's from Heidi, one of our viewers today. So Heidi said, my mom has hallucinations and delusions. Is this part of Parkinson's dementia? So is there a connection between dementia and these symptoms?
Yes. So hallucinations are more common in people who have dementia due to Parkinson's disease. They often go hand in hand, dementia and hallucinations. So if people can have hallucinations without having Parkinson's dementia, but in people who have Parkinson's disease dementia, it's very common that they also have hallucinations.
Okay, that's good to
And it
know.
also plays into that difficulty with knowing what's reality and what's not, because the dementia makes that understanding more difficult.
Okay. So, delusions. So can we talk a little bit more about delusions? Because I know that can be really challenging, particularly if, the person's not realizing that they're having a delusion. I know, often too, it can be, delusions about, someone, you're draining the bank account, or you're, having an extramarital affair or whatever. So how does someone address that with the loved one, particularly if they don't believe that they're having a delusion?
So delusions, kind of by definition, are difficult to address.
Yeah.
So those are some of the most common types of delusions in Parkinson's: the thinking that your spouse is cheating on you when they're not, or that family members are stealing money. But just the nature of the beast of a delusion is that it doesn't matter how much you try to convince them otherwise, they're still going to believe that. That is still going to be their reality. So I would encourage, anybody who's having delusions, Generally, people with delusions it's affecting their daily functioning. It's distressing either to the patient or the caregiver. Talk to your doctor about them, because often that's the point where it's time to start a treatment for psychosis.
Okay, so speaking of treatments,
Mhm.
so if someone is starting a new medication to help with their hallucinations or delusions, the question is kind of what should they be looking for to know if it's working well? Are there
Yeah. So a reduction in the hallucinations
simply
would be the main thing. And
okay?
some of the medications can take time. So it's not always going to be, in the Parkinson's world, we're used to carbidopa, levodopa, where you take it and then, within 30 minutes, you can see the effects. But with the hallucination medications, it's not always that quick. So you might have to stick with it for weeks to know that it's helping.
I think that's an important point. So for people to know that it's not going to be an immediate over the night, overnight response. So yeah, that's good to know. And I guess kind of like related, once the hallucinations and delusions begin, um, is it typical that they are happening within a short period of time? Is it usually followed by like a period of time where maybe they don't have it? So like, I guess the question is more like, once they start, is this consistent, or are they going to maybe have hallucinations and then not have it, you know, and then they come back again all of a sudden, or
Right. So that can vary from one person to the next.
okay.
If there's a trigger that you can identify and then reverse it, then oftentimes the hallucinations will go away, at least for a
Mhm.
while. So, for example, if somebody starts a new Parkinson's medication, like a dopamine agonist, and they get hallucinations, you stop the dopamine agonist, usually the hallucinations go away, unless they restart the dopamine agonist, or maybe years down the line as the disease progresses, they might come back. If you are in a situation where it doesn't seem like there's a particular trigger that you can identify and reverse, and
Mhm.
it's more so that the Parkinson's is very advanced and there's, Parkinson's disease dementia, then oftentimes it's, once the psychosis is there, then at least to some degree, it's often there to stay.
Yeah.
It might become more mild, or you might have periods of reprieve with treatment or medication adjustments, but it's harder to make them go away entirely unless you have a trigger that you can reverse.
Mhm. Okay. Um, and the medications for hallucinations and delusions, are there specific side effects to those?
Yeah, it depends on which medication you're taking, of course. So you would talk about specifics with the doctor who's prescribing it. In general, there's two classes of medications that we'll use to target hallucination. One is cognitive enhancing medications. So these were medications that were originally created and FDA approved for dementia. But in people with Parkinson's disease, they can also help the hallucinations. And then the other class of medications that we use are called antipsychotics. And these were medications that were specifically created and FDA approved for hallucinations. Um, the vast majority of them were created for hallucinations due to different reasons, like schizophrenia or bipolar disorder, not specifically Parkinson's, but they are medications that target hallucinations specifically.
Okay. Let's see, what else do we have here? Does exercise help with these symptoms?
Exercise is great for Parkinson's overall. So I always encourage exercise,
Right.
unless your heart doctor says you can't because of heart issues or whatnot. There always has to be a caveat, but in general, um, exercise is great for a variety of Parkinson's symptoms. And there's some data out there that it's good for cognition. I don't know that it's been specifically studied in hallucinations. I'll have to look that up. I haven't seen the study, but in general, for cognition, it um, it can help with
Right.
that.
It's worth a try, right?
Yeah, I think so.
One of those things that can't hurt. And I think we're getting into a theme here. What about like, is there any specific specialist that people can see for psychoses? Is it helpful to see to seek counseling, maybe the care partner, are there additional resources for care partners?
Right. So, as with a lot of things in Parkinson's disease, often we have a multidisciplinary approach. And it kind of depends on your doctor and your doctor's comfort level. A lot of movement disorder specialists are very used to and comfortable treating hallucinations in Parkinson's disease. The other type of specialist that you might see is a psychiatrist. Treating hallucinations is what they do all day, every day. Hallucinations from a variety of different causes. And those are the main two types of doctors that you'll probably see for your hallucinations in Parkinson's disease. And then a therapist can be helpful for comorbid depression, anxiety symptoms that go along with hallucinations a lot of the time. And so frequently we'll refer patients to therapy. And then for caregivers, we have a social worker in our clinic, and I know that not all clinics have social workers, but they're a really fantastic resource if you have access to a social worker to get, resources for caregivers.
Great. Let's see. I think this is a good one, and there's actually two similar. What makes hallucinations different from dreams? And similarly, are nightmares considered psychoses?
This comes up a lot in the clinic. So hallucinations are whenever people see or experience something that's not there when they're awake. And dreams, even if they're very vivid, are a phenomenon that happens during sleep. So that's the distinction: is are you awake, are you asleep? Sometimes it's hard to tell, actually, if you're in the middle of the night. You're kind of in and out of sleep and dream, and sometimes dreams can kind of it can seep into wakefulness. We call those hypnopompic hallucinations, where you wake up from a dream and for a few seconds you kind of see a hallucination there. And that's not specific to Parkinson's. That can be a normal, actually. But there can be some difficulty distinguishing hallucinations from dreams. And particularly in Parkinson's disease, people tend to have very vivid dreams because of this phenomenon called REM sleep behavior disorder, where people start acting out their dreams and their nightmares. And so the distinction is sleep versus wake, but admittedly, it can be hard sometimes.
Interesting. Yeah, this person here says too that during the day, the hallucinations seem to be evil faces, and then they experience nightmares at night. So like that seems like maybe there's some kind of relation there.
So sure, that's certainly possible too, that it could be a combination of hallucinations during the day and then similar nightmares at night during sleep.
Sorry, I feel like I'm kind of all over the place here. So Dave is asking, could my ex-wife's delusions and behavior be related to suspected Lewy body dementia, or her broader diagnosis of MSA? So we haven't talked about LBD or MSA. So, is there any relation there?
Right. So, let's talk about nomenclature a little bit. So we talked about Lewy bodies, and we looked at what a picture of a Lewy body looks like. Those aren't only seen in Parkinson's disease. So there's also a related disorder called dementia with Lewy bodies, and many of us in the field feel like this is on the same spectrum as Parkinson's disease. And people who have dementia with Lewy bodies, they tend to have hallucinations and dementia early in the disease course. It might even be before they get drunk or the motor symptoms that you typically associate with Parkinson's disease. There's an umbrella term called Lewy body dementia that encompasses both that dementia with Lewy bodies and also Parkinson's disease dementia. So for many people, you can think about Parkinson's disease dementia and Lewy body dementia in the same vein. And MSA is a similar disorder, a similar neurodegenerative disorder that's also caused by a buildup of the same protein called alpha-synuclein. Alpha-synuclein is the protein that's clumped up and in those Lewy bodies, but the location of the alpha-synuclein is in a different type of cell in the brain. So it's a little bit of a different disease. So specific questions of diagnosis, like, is this MSA, is it Parkinson's, is it DLB? I'll leave that up to your doctor. But all of these types of diseases can come with hallucinations.
Okay, I did not know that. All right. Let me just take one last look here. I think we addressed kind of all the themes. You did great. I fired them at you pretty quick here too. Yeah, I think we kind of hit them all. So that's great. Anything else that maybe we didn't, or that you kind of thought of after the fact that you might want to just share?
I think we covered all the
Okay.
bases. Nothing comes to mind.
We did great. So that's fantastic. All right. Well, thank you so much for sharing all of that with us. And before we close, I do just have a couple more final notes to share with everybody. So once again, I want to thank our sponsor, Acadia Pharmaceuticals, for supporting the mission of our foundation. So thank you so much, Acadia, for your support of today's program. I also just want to share a quick note about a study. This is the Persevere study, it's called. And so the Parkinson's Foundation is proud to be a partner in a NIH-funded study exclusively for family caregivers of people with Parkinson's disease, particularly those experiencing cognitive change, hallucinations, or dementia, including Lewy body dementia. This study, called Persevere, is entirely virtual. Persevere was created to try to understand whether and how a disease-specific caregiver-centered educational intervention can improve caregiver knowledge, confidence, strain, and health outcomes. So you can learn more about that study by visiting the Persevere website that you have here on the screen. You can scan the QR code that's here. That'll take you right to that page, or you can email our study team, which is here, persevere@rush.edu. So we're happy to be partnering with Rush University on that study. And then I also just want to share about PDG Narration, Mapping the Future of Parkinson's Disease. This is our global research study that provides genetic testing and genetic counseling at no cost for people diagnosed with Parkinson's disease. By joining PDG Narration, you can discover your individual connection to the disease while helping map the future of tomorrow's breakthroughs. So you can learn more and enroll in this research at parkinson.org/PDG Narration. Very easy to be involved with PDG. And then if we didn't get to your question today, I think we got to most of them, or if new ones come up as you process all the information that we shared with you today, we're here to help. So visit our comprehensive website at parkinson.org. We have a wealth of resources there for you. Or you can reach out to our expert team directly by calling our helpline at 1-800-4PD-INFO. Great people that work on our helpline are there to help you. And then let me just see, before we wrap up, one last favor to ask. Your feedback is always important, and it's essential to helping us shape our programming. So as the webinar concludes, a survey will pop up on your screen. Please take a moment to just share your thoughts with us. Let us know what other topics you'd like to see from in future sessions. We do read those, we do pay attention, and so we welcome your feedback. Thank you again for joining us today. Take care. We look forward to seeing you at our next Wellness Wednesday soon. Thank you.